you might have the best clinicians in the whole wide world who are also, side note, the best documentation specialists ever and know all the rules. But if they're not complying to the signature requirements, which we have an article on and a video on, so you can look at those later, no one's going to read your chart because they're just going to throw it in the trash can. Hi everyone, my name is Mariam Treystman from the Home Health Consultant, and today we're going to be talking about QAs. What is a QA? But first, if you like our content, please like, share, and subscribe. So what is a QA? A QA, or also known as a Quality Assurance Specialist, is someone who reviews charting and other documentation for compliance, pretty much. Long story short, they're just looking over things to make sure things are compliant and that people are documenting according to the standards. So some key kind of responsibilities for them are making sure that things come in on time and then reviewing them for completion, for accuracy, for compliance, and things like that. Another kind of little thing that they can do is keep note and keep track of common issues and deficiencies with the charting of the agency, and then work on improvements for that, or at least report to clinical leadership to have improvements in that area. QAs are very important in home health and hospice agencies. One of the reasons that they're so important is that the care being done in home health and hospice is off-site. So you kind of have this documentation rolling in at random times, whereas in an on-site facility, documentation is factored into the timing of things. Like, for example, if you're in a hospital, you are doing your treatment and then you're documenting your treatment, all within the scope of the time that you're on site. So like all of that stuff is kind of accounted for. In home health and hospice, specifically home-based hospice, not facility-based hospice, the clinician is going and doing the treatment, but then they're often documenting at home or somewhere else at a different time. They might take down some like key notes of things that were important, vitals and other like important, information or whatever it is they need. But ultimately the full documentation is done or completed or finished or, whatever, not bedside. And so sometimes little details are missed, sometimes this, sometimes that, but also separately from that, you might have, let's say, 5 clinicians or 6 clinicians, like different disciplines, right, on a chart, on a case. And so you might get like nursing notes before you get therapy notes. And it's all kind of coming in at random times. Yes, the rule is that we should have notes in the chart within 7 days of the visit. Sometimes people are compliant to that, sometimes not. It just kind of depends. But the point is, even if you are just like on the dot compliant with all of that, within those 7 days, you might get like a nursing note from 5 days ago come in, and then like a PT note from yesterday come in. Like it's just kind of like random when you get this stuff. And so the QA person in the home health and hospice agency, they're like putting together this puzzle piece of a chart and reviewing based on just kind of like the timing of when things come in. And they have to make sure that first and foremost, what they're looking for is that we are filling everything out. Let's just start with that, right? Like one of the main things, like one of the kind of charting deficiencies that you can see a lot if clinicians aren't careful in their charting is that they can leave just blanks. And leaving a blank is not the same as saying, let's say, for example, if you're describing like the condition of a patient, even if this is like some multiple choice kind of choosing of condition status, right? A blank in that section is not the same as saying no problem in that section. And so that's kind of a lot of what QAs are looking for. They're looking for blanks, things that we missed, things that don't make sense in the greater context of the chart, that you're addressing everything in the care plan, and things like that. And so, for example, if you haven't addressed certain things in the care plan, they might ask about it and whatever, and then you have the chance to address it at the next visit and things like that. And there are, of course, different kinds of QAs, but for the most part, they are here to review documentation for the purpose of compliance to a whole number of regulations, compliance to the rules, compliance to care plans, all that stuff. Compliance to documentation principles, compliance to the policies and procedures of the company. So they're kind of like the person who's just like making sure all of that goes together. There are different QAs for different reasons. And kind of depending on the size of your agency, you're either going to have like one kind or several kinds of QAs. So one question that I get a lot is, should our QA be a clinician? Like everything, right? The answer kind of depends. And the depends of this is, if you're a small agency, especially if you're like first starting out, you could get away with like with just like one QA who's non-clinical. Because in smaller agencies, as you're starting out, we're talking like 20, 30 patients maximum. You're maxed out at 20, 30 patients. You can kind of get away with a non-clinical QA, because the concept and the assumption here when saying that from a structural perspective is that you have a DPCS and their designee, right? Or you already have clinicians in the office. And when you're small, the DPCS can be a lot more hands-on and kind of serve as a QA function as well. And so this non-clinical QA, whether they're experienced or not, there are certain things like you don't have to be clinical to notice that, okay, this is like the silliest, most basic of examples, but like that the clinician didn't put like their title when signing something, right? Okay, that's not a clinical thing, but it's a problem in an ADR. If you don't have titles in signatures and names in ADRs, they're just kind of throwing that page away. So even if that whole charting, like whole page is just like a perfect shining example of like fantastic documentations going right in the trash can, doesn't count. If you're not, complying with signature requirements and things like that. So there are a lot of little technicalities that are so important to keep track of and comply with, just because these little details like signature requirements could be the difference. You might have the best clinicians in the whole wide world who are also, side note, the best documentation specialists ever and know all the rules. But if they're not complying to the signature requirements, which we have an article on and a video on, so you can look at those later, no one's going to read your chart because they're just going to throw it in the trash can. And so the page that didn't comply with signature requirements might be the thing that justifies your homebound status, justifies your medical necessity, justifies your terminal illness status, right? And so if that thing goes in the trash, the whole chart's denied at that point. And so there are a lot of little technical things like this that you can have a non-clinical person do an initial upfront review for. So if the question is, can my QA or can a QA be non-clinical? The answer is yes. But, and the but is that there still needs to be a clinician who ultimately reviews the thing. It just doesn't have to be your QA. It could be your DON. And so when you're in this, or whoever it is that's clinical in your office. So if you are in a small agency, small enough that the DPCS can be hands-on and have the time capacity to review all the critical elements, great. You can have a non-clinical QA starter, because truly it is a waste of your DPCSs and your designees or your nursing supervisor, whoever that is, their time, or case manager, whatever. It is a big waste of their time if they're out here checking your chart for like, did the person put their title? Did they time the order? Did, whatever, all these like little details like this. you want to use if you have a non-clinical QA, you really want to use them for, here's some cool things you can use them for. Signature requirements. Are all the pieces here? This is a really good, like, oh, cool, you gave me an admission package. You admitted a patient and you gave me the admission package. But your, this is silly, but like the consent is missing or whatever, right? Like, so just checking a checklist of like, are all the big pieces here? Number one. Because if your DPCS or whoever is reviewing a chart and there's like critical elements missing, like that's just how, whatever time they've spent reviewing that chart is just a big waste of time, because chart review can only happen in full. That doesn't mean the whole chart has to be there, but the whole chart up to that point has to be there for it to make any sense. So if you are reviewing a chart and let's say you're like 3 weeks into the treatment and you have notes up to 2 weeks into the treatment, congratulations, you reviewed 2 weeks of chart. You haven't, and like, let's say you have a couple of the third week notes, but not all of them, right? Like there's multiple disciplines and stuff. You have really only reviewed 2 weeks of that chart. You have not reviewed 3 weeks of that chart. You've reviewed the amount of chart that is complete, because every additional little piece that comes in could fully change the dynamic of what's going on there clinically. I am not a clinician, so I'm not like, out here reviewing charts all day long, but I've been in the industry enough where as a non-clinician, I could look at a chart and I can find you most survey deficiencies that a surveyor could find. Not hyperclinical problems or problems in hypercritical. Like I can't do wound care. I can't do the things, but I can read the things and tell you if things are missing, at least on the level that you would get like a deficiency at surveying. Most people who would work in a clinical or non-clinical QA position, whether they have experience or not, can over time learn these things, because clinical charting is a science. There's some art elements to it, but it's mostly a science. There's formulas. Clinical treatment is formulas. It's I don't think I'm expressing this properly, but my point is someone non-clinical can learn to review very well over time. But man, you really want to have a clinician take a look as well. You don't want to just like leave it to like someone like me pretty much to just like be your only QA option. So can my QA be non-clinical? Yes, if ultimately there is a clinician managing this and getting their hands on it over, at some point, whatever. The way that I see that this scales and why people do this is because having a clinical QA is very expensive. When I say a clinical QA, I mean a licensed clinician. And so at that point, they're pretty much like your nursing supervisor or this or that, right? Like they become a clinical staff member in the office. And so when you're just starting out, if your team is small, you can have a non-clinical person. But as you grow, where you want to start considering scaling in clinicians on top of the non-clinical personnel, that's how you kind of grow. You can get the non-clinical person to do initial audits and stuff like that. Then the clinical person does the more in-depth review. From here, when you get to the point where your DPCS or whoever it is that's the clinician that is doing the more in-depth review or whatever, when they no longer have the capacity to do that is when you start dropping in the clinicians who can review. And so you're scaling with non-clinical reviewers. If your non-clinical QAs are good, the better they are, the less time the clinical person needs to spend on the review. So at first you're hiring, let's say, for example, this is like just, case study. You can do it differently. You can hire a clinical reviewer of 50 years as your first hire. That's fine. Do your thing. Even better. But most people have resource issues and things like that, so they can't hire some nurse for 50 years who's seen it all and things like that. So as you get non-clinical QAs, as they get better at their job, hopefully the agency is also growing a little bit, right? So like the initially if let's say their capacity is 20 patient census, over time their capacity increases a little bit, but I would never have a single QA on more than 30 patients at a time. It's just that's where you start to fall into like oh, we're throwing it in the backlog. We have a backlog now. And the problem with this is that QA activities are really time sensitive because you can't like review a chart 3 months from a visit 3 months ago and be like, hey, what did you do? You know, you really need to be documenting clinical stuff kind of contemporaneously, like at the time or right around the time. It shouldn't be something that you're like, oh, in this visit, I don't know, 6 months ago, 3 months ago, 2 months ago, whatever, did I check this one med and was it a tab or a capsule? You know, like this kind of nuance. The stuff that the QA finds is probably not the stuff that stays in your memory for 2 months or 3 months. If you missed it, then 3 months later, your memory is not sharper. So my point is that stuff needs to happen on the spot. And so past like 25, 30 patients, you're looking for someone else. Even super QA can't QA past that, you know. Anyway, so let's say this person's capacity increases, is non-clinical or clinical, whatever, as your agency grows a little bit. And so maybe you're going from like 15 patients to 20 to 25 to 30. Their skill increases and maxes out right around there. Their skill increases creates less work for the clinician who ultimately reviews. But at 30, you're looking at a second initial reviewer. You can tier them, meaning they're doing different things, or just this guy does these cases, this guy does these cases. But at some point, and that's going to depend on the skill of the initial reviewers, right? Your DPCS person or your clinical person who is reviewing, they're not going to have capacity for this. So that is when you start bringing in the clinical QAs. So that's kind of how you scale your QA operation. If you're trying to have them do different things, there are different time points that they can look at, because if you're really having QAs work on compliance is a small word that means a lot of things, you know. So there's a lot of different compliance points. So there's regulatory compliance, there's billing compliance, there's your internal procedural compliance. There's so many versions of AK. What are you complying to? Like, what are we complying to? Like Medicare COPs and your accreditor standards, that's regulatory. Then there's like billing requirements. That's its own thing. Then there's like, I know the processes of my company and I need to make sure those processes are that's its own thing. So you can start separating like that. The QA that looks at billing compliance is probably looking at it right before it gets billed. It's like a final review prior to billing. Whereas someone doing regulatory compliance and procedural compliance kind of stuff is looking at the chart as it comes in, because you want to catch those things as they're happening and fix them as they're happening. Billing too, but you can't have like 17 people review everything that comes in, right? So either one person knows it all, or you have different people that are looking at different time points. This is a whole separate video of how to structure your company, and could be like some 10-day course. So maybe it will be one day, but anyways, that's that for that. There are also consultant QAs that you can hire, and that's cool, great. And occasionally you should have external clinicians look at your charting just to kind of get a extra set of hands. This is kind of like the danger of, this is what's hard in this industry, and maybe you'll relate. So there's a lot of people in the industry that say they can do things and then like can't. And you find out at survey if they can or they can't oftentimes. So like, let's not wait to confirm someone's skill in a clerical perspective or clinical perspective, but like in the office, I don't obviously for clinicians in the field, we're doing competencies, we're validating their skills that way. But in the office, let's not like wait and see at survey if they actually know what they're doing, right? So, and that, sorry, DPCSs, but that goes for DPCSs too. Like, you could have somebody who is just top clinician of the whole wide universe, like in this galaxy, okay? But they might suck at documentation. Or you might have like the best documenter who like couldn't take a vitals, couldn't take vitals if their life depended on it. Like, I mean, whatever. People have different skills. So my point is, we have a lot of required regulatory processes to check the skills of the clinicians in the field appropriately. We need those. But as an agency owner, especially with the smaller agencies, especially in places that don't have a very developed home health and hospice industry, like you might be like 5 home health agencies in the county kind of moment or something like that. If that's what you're working with, having these external QAs to confirm the skill of the QA is an amazing and invaluable. So because of that, having external, like some kind of like QA consultant to just do a chart review occasionally, like once a year or whatever, would be nice. And when you are looking at external QA consultants, you really want to consider, like, what are we reviewing for, right? Like, are we reviewing for like ADR stuff, which is the billing kind of stuff? Are we reviewing for like claim-based compliance? Are we reviewing for COPs? Like, what are we doing here? So you really want to hone in on that. I think I've said this in a previous episode. If I didn't, quote me. The time to do ADR QA is during the treatment, not when you get the ADR. So any QA that you have working for your company, whether they're clinical or non-clinical, at some point needs to start getting really familiar with local coverage determinations and other ADR important things, because they need to review that. That's what you're doing. So if you're talking about QAs, we're looking at people who can review for COPs, accreditor standards, your policy and procedure adherence, billing requirements, and ADR preventative things to prevent denials. This is what you're looking for. This is a perfect QA who can do all of those things. So what do? They do chart audits. They just like review all the things that come in. If you keep clinical data for infections and things like that, right? This is kind of like part of the big picture. You have QAs that just like do the, clinical charting review. And then, and really we're dipping into like DPCS territory here, but super QAs can start picking up on trends and trying to run project improvements, so like QAPI processes and things like that. So if you do have a QA, make sure that your QA is part of your QAPI committee, because often, even more so than the DPCS, they will have a lot more internal knowledge about the stuff that's wrong. If they're doing a good job, by the time the chart gets to the DPCS, it's already much better than it was initially. So the DPCS will often, and like, whatever, DPCS nurse, when I say DPCS in this context, DPCS designee, nursing supervisor, or case manager, whoever that is, that's the clinician reviewing stuff ultimately, they should not see the procedural and all those errors, because those errors should be resolved by the time they come to the DPCS. I'm not saying like fixed, but like they shouldn't be looking at a chart with like a whole missing form and things like that, right? So you really want to have your QA part of your QAPI committee, because they're going to have the most, like the deepest concept of what's going on with your charting and where your process improvement should be. And lastly, why do agencies use QAs? Helps with deficiency prevention and just general compliance, helps you understand where your problems are. And they're really like the person really communicating with your field staff in terms of like improving your documentation and stuff like that. So that's that. That's the QAs. QAs are very important parts of home health and hospice agencies. If your company doesn't have a QA, man, please, your next hire should be that. I mean, in your office, obviously, you need to always hire clinicians just to have some kind of cohesive flow in your charting and make sure that your clinicians are constantly improving. A lot of times they don't really talk to each other outside of mandatory case conference times and things like that. And so obviously in hospice, you have IDG every couple of weeks, so that's different. But the QA is really, really kind of the glue that's putting all this together. So that is QA for quality assurance. And please work with your QAs, appreciate them. They're very important. And if you have good QAs, they can be the difference of ADR approvals and denials, survey passing and not passing, and things like that. So again, that's QAs. My name is Mariam Treystman for the Home Health Consultant. And if you like our content, please like, share, and subscribe. Thank you.